So since 75, IOL power has been calculated using basically two parameters, that is keratometry and axial length. But now and today we can customize the power of IOL to achieve near plano results even in highly myopic or hyperopic eyes. And there are a group of patients who greatly value their emetropia. And when you break news to them that they require spectacles after the cataract surgery, they are extremely disappointed. So what are the major sources of prediction error for IOL power calculation? ELP prediction accounts for the major part, that is 35%, followed by axial length 17% and keratometry 10%. Few subjects in the field of ophthalmology are as complex as IOL power formulas because it involves the help of mathematicians, and we ophthalmologists by nature are not very fond of mathematics. Earlier formulas had some assumptions. That is, there was fixed ratio of anterior corneal curvature and posterior corneal curvature. Cornea was treated as a thin lens with a refractive index of 1.33, and this used to give us correct result in average eyes but not in atypical eyes. And there were some other hurdles in accurate estimation because there were some more assumptions. It was assumed that shorter eyes and flatter K eyes will have shallow AC and shorter effective lens position, in contrast to longer eyes and steeper K eyes, which are supposed to have deeper anterior chamber and longer effective lens position. But Holliday told us that there are 9 types of eyes. Even in eyes with normal anterior segment, 80% may have short and 90% may have long eyes. And in eyes with normal axial length, 2% may have shorter or longer anterior segment size. So relationship between the anterior segment and axial length is not proportionate in 80% of short and 90% of longer eyes. So older formulae are bound to fall in short and long eyes. So is it bad to keep using the older formulas? Yes, because with that only 1% of the surgeons achieved accuracy more than 92% with plus minus 0.5 diopters. And this was renal medal lecture which was given in 2016, which told us that if we change with times, we can have 91% of eyes within plus minus 0.5 diopter of the target refraction. So what are these newer formulas? I'll just going to enumerate the basic features of these newer formulas like Hoffer H5, Ladas, Olsen, Barrett, and Hill RBF calculator. Prediction theory says more the number of variables to describe an event, more accurately the outcome can be predicted. So we have moved on from 2 parameters in 1988 to 4 variables in Olsen, 5 in Barrett Universal 2, and 7 variables in Holliday 2. Artificial intelligence is utilized in Hill RBF and ray tracing in Oculus and Phaco Optics. And there are some variables which are intermediate factors which help us to arrive at effective lens position. SRKT while had A constant, Haigis had A0, A1, A2, Hoffer Q and Holliday 2 have anterior chamber depth, and Holliday 1 has surgeon factor, Olsen has C constant, and Barrett has lens factor. So what are these lens constants? They were actually developed during the later stages of regulatory processes and with limited number of cases when plano convex lenses were used and convex ultrasound biometry was used. But with this, we used to have some error. So it makes sense to optimize the lens constant. Either you can analyze your own data or you can use software like www.drhill.com or Dr. Haigis ULIP website. Surgeon who does not personalize his constants will constantly have some refractive surprises. This slide on the left shows that within 0.5 diopter, without optimizing, if you had 18% success rate, this can move to 70%, and within 1 diopter you can move from 50% to 95%, as shown on the pink bars in the right side of the slide. So what is this new formula? Barrett Universal 2 is recommended now for all types of eyes, whether short or long eyes. Hill RBF uses artificial intelligence and pattern recognition, and the predicted accuracy of 91% of eyes within 0.5 diopters. Olsen formula uses ray tracing. Lada super formula intelligently combines the best performing portions of multiple 3rd and 4th generation formulas. Kane formula uses, besides axial length, keratometry, anterior chamber depth, also lens thickness, central corneal thickness, and gender of the patient to make its predictions. EVO 2.0 formula is based on theory of emetropia, and it's a thick lens vergence formula. Intraoperative aberrometry is best valuable as a confirmatory or complementary test. It is not going to make lens calculations obsolete in near future, and the only indications are in post-refractive surgery cases and in astigmatism correction. Ray tracing IOL calculation is almost equivalent to third generation formulas in normalized, but it is superior in odd eyes with extreme axial length or with the different corneal condition like post refractive eyes. But there are limitations of ray tracing formula, and because it still depends on the accurate estimation of the effective lens position, so there is no reason to switch to ray tracing formulas. Hill RBF formula not only gives us IOL power, it also tells us the accuracy level, whether it is inbound or out of bound. That means whether your patient data parallels the data in the database of the this Hill RBF, that means it is inbound, otherwise it is indicated as out of bound by red dots. If we compare Barrett and Hill RBF, both are good choices. They are current, they are more sophisticated, and although they use completely different premises, like Barrett uses the artificial intelligence, Hill RBF uses artificial intelligence, and Barrett uses paraxial ray tracing formula. But both these methods surprisingly give recommendations that are within 0.25 diopters of each other. So what should I do? Should I use multiple formulas and compare or average the results? Douglas Koch follows this policy, but Holiday and Barrett says horses for courses, that is specific formulas for specific condition. So what is the best way to deal with eyes? We always used to say Hoffer Q, but the conventional wisdom has been replaced by the latest literature, and they say either use median of Holiday 1, Holiday 2, or use just Barrett and Hill RBF. And the problem in longer eyes is that we get hyperopic surprises, particularly when we are dealing with eyes more than 24 millimeter. And what are the three formulas which work well? These are the ones: Barrett Universal 2, again Hill RBF, and these are the newer formulas which are available on site. You don't have to pay anything. Barrett, Hill RBF, Olsen, Kane, Evio, Pearl DGS, all these formulas are available online. And this was meta-analysis which was published in Journal of Cataract and Refractive Surgery, and which they have compared all these formulas in shorter axial length, medium axial length between 22 to 26, and longer axial length more than 26. And you will find that the formulas which are best performing are Kane, followed by Evio, followed by VRF, Barrett Universal 2, Hill RBF, Pearl DGS, VRF. SRKT is not there in the first 5 or 6 best performing formulas. This was other meta-analysis which was published by Meles in 2019, and it also gives us almost similar results. So what are the steps you can take to maximize the likelihood of getting better outcomes? Please optimize your constants, validate your measurements if your readings are outside the average, that is axial length less than 22 or more than 25, keratometry is less than 40 or more than 47. Take the measurements yourself, because ophthalmologist is the most knowledgeable part of the team. So don't remove yourself from the process. Spend extra time counseling the patients with short eyes or previous refractive surgery, and don't just keep doing what you have always done, because then you will get the same error which you have always got. And but we are still stuck at 90% accuracy within 0.5 diopters. Limit is now not the formula, limit is the least count, that is the precision of the measurements which are put into these formulas. And the precision limit for keratometry is 0.25 diopter. For axial length and anterior chamber depth, it is 0.1 to 0.2 millimeter. So these error limits keep us at 90% accuracy within plus minus 0.5 diopters. And again, there are some measurement errors in the IOL manufacturing tolerance given by ISO. Imagine that you have calculated the power of your patient to be 21.3 diopter, but the nearest power available is 21.5 diopter, and you will find from this chart that the error permitted is 0.4. So even if you have done correct estimation, good accuracy, good formula, good surgery, still you will have error of 0.6 diopter, that is not within your control. So has the stage come where we can use single formula for all eyes? I think it is difficult to say, but the formula which comes closest to that accuracy is the one, Barrett Universal 2. This is the chart which shows that these are the various formulas which fit into the various axial length less than 22, 22 to 26, and more than 26 millimeter. So improvements in technology have allowed accuracy of biometry to double every 5 to 10 years. So previously 80% accuracy was acceptable, but now 90% is achievable. So we should always strive for what is achievable and not settle for what is acceptable. Smartness is learning from not only your own but also from others' mistakes. So let us not only become experienced but also smart. And now we are on the verge of level of accuracy for refractive outcomes never before seen in the field of ophthalmology. But to fully enjoy this, use validated measurements, optimize your lens constants, and adapt to newer technologies. And we are thankful to all these ladies and gentlemen for bringing us to this level of accuracy: Holiday, Wang, Koch, Warren Hill, Thomas Olson, and Barrett. Thank you everyone for your kind and patient hearing. And with this, I always also extend invitation to all of you to please come and attend DOS midterm conference, which we are organizing in New Delhi from 2nd to 3rd September. Thank you.